everybody for joining us. So I think I want to start just by introducing myself and letting our panelists introduce them. We've got a couple of questions that we'll discuss up here, but we definitely want to leave room at the end for questions from you all. So please feel free, as you're listening, there's cards on the seats. You can use those to write questions, or we'll circulate the microphone at the end. I'm Dr. Amy Weimer. My pronouns are she, her, and I'm the medical director of the UCLA Gender Health Program, which is, obviously, as you know, UCLA is a large academic institution, so we're a multi-specialty collaborative there providing clinical care in all areas to people who are transgender and gender diverse. And our program started in 2016 and has grown quite rapidly since then. There was clearly a very huge need for it. So I'm here sort of representing that large academic institution viewpoint.
My name is Alexandra Magallon. I go by feminine pronouns. Is there anything else that you want us to say while we're?
I'd be interested to know kind of what your role is.
Yeah, okay. So I, for work, I'm the client advocate for the Transgender Economic Empowerment Project at the WLA VA Center. I also am board of directors of WLA Pride, and I am also co-chair of the Transgender Service Provider Network Los Angeles. That's about it, I think.
That's not.
Hi guys, my name is Atara Geft. I go by feminine pronouns. I am a physician at the WLA VA Medical Center in the Women's Clinic. I'm also a clinical instructor at UCLA for the medical students and residents. A few of us have come together and we have made the transgender health team at WLA VA for the greater Los Angeles area, starting also in 2016 on a collaborative effort of physicians, endocrinologists, pharmacists, social workers, psychologists, and mental health providers. And I'm here representing us today.
Hey folks, my name's Frankie Darling-Palacios. I use they, them pronouns. I identify as genderqueer. My current employment is at the Los Angeles LGBT Center, where I serve as Outreach and Enrollment Coordinator. One of the programs I oversee is the Audre Lorde Health Program, which sees sexual minority women. And I also coordinate benefits and education, counseling, and enrollment into health insurance and health insurance navigation for our transgender clients, and I oversee the Community Advisory Board. I currently serve as commissioner for the Commission on HIV, and I also sit as secretary for the Transgender Service Provider Network, which is the oldest organization / network in the county that is a trans-led organization. And I also serve as Community Advisory Board for LA Pride. Recently, I've been named a paid family leave advocate for the Employee Development Department at the state level. So I'm just really happy to be here, folks, and answer questions.
So we have a great balance of sort of larger health systems and community-based organizations and a great breadth of experience. I think the plenary speaker did a really nice job of showing us how much is still present as far as health disparities and vulnerabilities. In the trans and gender diverse population, we know that rates of depression and anxiety are significantly higher than in the general population. Suicidality remains the #1 cause of death and the biggest sort of health crisis. But we're also getting very, very reassuring information about the benefits of gender-affirming care and of intervening really as early as possible. There are studies looking at youths who transitioned in childhood or in adolescence, and their mental health outcomes were equivalent to general population. So we know that being able to provide gender-affirming care is a huge benefit from a health standpoint. We know substance use rates are significantly higher in this population. Sexual risk-taking behaviors significantly higher. Often those two things go together, and that's certainly one of the risks. So one of the things that we really need to be thinking about is how can we start to break down some of the barriers to care. And one of the things that we discussed sort of as a panel, some things that we've all seen throughout health systems that can be barriers to care. And one of them is that a lot of our care in certain areas has been historically delivered through sort of gendered spaces. So for instance, if you go to a gynecologist as a trans man, that can be a really challenging experience. So I wanted our panel to talk a little bit about where they have seen these gendered spaces in healthcare, and maybe some either experiences that you have had within your systems or ideas that you have had about how health systems can work around these sort of historically gendered areas of care.
I can start. So, like I mentioned, I sort of come into the world of transgender health maybe from a different approach than I feel really honored to be on this panel because I know everyone here has had so many years in transgender health. I'm trained in internal medicine. I did a fellowship in women's health, and I started my career off as a women's health physician at the VA, at the women's clinic, and I only was treating women's patients, and just specifically at the women's clinic. And we had noticed that we had a lot of our VA patients coming in, and had quite a number of transgender patients coming in, trans female patients coming in, and feeling that they weren't getting the care that they wanted, that they felt very lost in the VA system. And that's why we came together and came up with this transgender care team. What we do at the VA specifically, because we do have a women's clinic and the majority of our female care gets done at the women's clinic, is that we give when a patient or when a primary care provider enters in a consult for a patient to be seen at the transgender clinic, they give the patient an option to be seen at women's clinic or the endocrine clinic. And a patient has the option, if they want to be seen, in the women's clinic where it's more female-centered versus or gender-centered versus an endocrine clinic where there's people coming in for not even necessarily transgender issues, but any issue, any endocrine issue, and they can feel that they're not sort of boxed into that situation. I think that, and Dr. Amy mentioned this she mentioned specifically trans male patients coming in and coming into a gynecologist. So at the VA, pap smears are only done at women's clinic. At the West LA VA, they're only done at women's clinic. PACC, which is our general clinic that men and women can both go to, they have the option. Most of our female patients come to women's clinic, but they have the option to go to PACC, which is the general clinic as well. They're not set up to do pap smears, and nurses aren't trained in pap smears. The providers don't feel comfortable sometimes doing pap smears there. They don't have, the instruments or the stirrups or things that are needed there. So we've had a situation where one of our trans male patients needed to come in to get a pap smear, and the only option for him was to come to women's clinic. And I know for him it was a really hard situation. He had to come in, he had to sit in the women's clinic, and was called by one of our nurses who just said, "Oh, Miss So-and-so," and he sort of got up and ran out of the room, super upset about that situation. And when we brought him back in, we were able to do it, and after that we sort of learned that this is not necessarily a comfortable situation from them, and we need to be able to offer services not only in the women's clinic but in our PACC or other facilities. And after that we put forward sort of either me or another physician walking over to PACC with one of our nurses and being able to do it in the general clinic, so that it wouldn't make our trans male patients feeling that they have to come to women's clinic in order to get their pelvic exams. One quick other situation that I've also encountered is also with housing in the VA. A lot of times we have substance abuse programs or homeless issues or housing issues, and we've had trouble to be able to find housing for our veterans if they needed it. Our trans female patients, a lot of them had policies in place that they have to have gender affirming surgery before they can be placed in the female housing units. And a lot of our transgender patients or trans female patients that I was dealing with that needed to be placed did not want to be put in, didn't feel safe in the general housing or in the male housing. And that was something that we had to fight and change some policies in the VA to be able to have them placed in the housing that's put aside for female veterans. So those are two situations that I've seen.
So in terms of, because we work at the center has actually been one of the oldest trans-specific clinics in the county for quite a while, more than 10 years actually. One of the things that we see as a challenge, not at our facility per se, because we've already established very specific protocol, when it comes to our trans population and our sexual minority women. So we are accommodating really nuanced identities or really specific identities that the center does have the ability to kind of address on a number of ways. As someone that does have an HMO though, as my insurance carrier, I think one of the biggest setbacks is our electronic health record keeping. And that is where it's not equipped when it comes to patients that have incongruent identity documents, or if their name, if they are in the middle of transition and if their name doesn't match their ID. A lot of things get overlooked by our LVNs or our MAs at the beginning, so when you're calling a patient and they might have an AKA, they probably didn't look at the AKA, they probably just looked at the last name or the first name, and they're calling that person by the first name. It makes it really uncomfortable for that patient to try to really establish that bond. So we have found ways at the center to kind of establish protocol when those things happen. But I think the first step is really figuring out, like, how can our record keeping be a lot better to make sure that we're ensuring that care. I, as someone that is now seeking prenatal care, I just feel like the entire healthcare system is completely gendered. I think that there's a huge miss, and I think the future in ensuring trans care is, that's great that a lot of facilities and primary care facilities are offering hormones. You can pat yourselves on the back for that, but at the same time, you know, what are you doing when this person has fully transitioned and you have a 50-year-old trans woman that transitioned 20 years ago and she needs an anal pap or someone needs a prostate exam? So those are the things that we need to do to kind of make sure that you're really looking above and beyond and looking at what kinds of things we need to figure out as facilities to ensure trans care for the future. Because right now, I think that a lot of what we see, especially through the TSPN, is specific organizations are starting their trans health programs. That's great. However, the future is really like, how are we going to continue to ensure that people are getting the preventative care that they need once they are physically done with transition, they've been on hormones for more than 10 years, and we're really establishing a rapport with our patients as facilities.
Good morning, everyone. So gendered healthcare, where to begin? I'm an intersex person. I recently found out after my parents both passed, left a will, and you know how things come out when will happens. So I found out after their death that now I was born intersex. So where to begin? So from the very moment that you are born, you are basically gendered. Gendered healthcare all the way until the day that you die. So with my own health, and I advocate for trans, intersex people, non-binary people, all the same. And I always ask this, why not, as a provider, am I not focused on giving the best quality of care regardless of genitalia? And what I mean by that is because when we think of sexuality, let's just let's go ahead and just go steps by steps. When we think of sexuality, we automatically assume X body has a penis, X body has a vagina. We don't ever get to think about intersex people. And I think as a society, we are failing our system, we are failing people, we are failing a lot of ourselves, including that, by not including intersex people, non-binary people, trans people as a society. So sexuality, we go into the sexual department, right? And what we automatically assume of somebody who's having a sexual life, that they are promiscuous, or perhaps somebody caught an STD, HIV. What are the first things that come to our mind? So that's one way of thinking of gendered healthcare, is what are the assumptions that we as a provider, we as a person, we as a society are thinking about sexuality in itself. Genitals. So I went to the doctor when I was experiencing some body issues. And the first thing that was told to me when I first started my transition was that a provider wasn't feeling comfortable in providing me health care. So what they did is they referred me 2 hours away. And this is in Washington State. But if we think about it, California is not that far away from Washington State. We are on the West Coast, and of course we are the most progressive states in the country. But when we are thinking as a country in itself, we're so far behind. So what happened is, after years and years, I realized that I've been dealing with the urinary tract infection. But what is the thing that I'm getting told when I'm coming in to see a provider is that no, you don't have a urinary tract infection because you don't have a vagina. So again, let's go back to sex, right? Let's go back to genitalia. If providers are being taught something at school based on gender, and we're not necessarily talking about all of the different sexual gender identities or all of the organs that are possible, how can a provider be fully adequate to provide service to anyone? Going into healthcare now, if I were to come into your facility, would I be able to find that the documents, the intakes that you are providing your clients with are all up to code? And what I mean by that is, at this point in time, a non-binary, I hope you all are aware, it has become a thing in the state of California. Are all of your records up to date with that? So my question would be that, have you updated that? Have you updated AKAs or preferred names, right? Because a lot of us maybe are not comfortable using the legal name that is assigned at birth, right? But we also need to be aware is, how is this person feeling comfortable? And are our providers, are our staff adequately or able to perform the just calling out the person by the preferred name? It turns into a trans 101, into a non-binary 101. So when I think about gendered healthcare, I want you to think far, far, far back, right? I want you to think in yourself. Am I the person that is assuming a person is of X gender just by how they look? How many of you would have said, oh, this person is intersex? Me. So that answers your question.
Thank you. And I think we touched on some really important points. One is medical training, right? What we learn in medical school or whatever your medical background is very, very lacking in this area. And so a lot of what we're trying to do is improve medical education, starting at the medical school level and even earlier, just to try to increase familiarity and comfort. The more, I think, Hudson, is it? The more that we standardize these approaches for all of our patients, the more second nature this all becomes. Another huge tool is the electronic health record. And so I think that's a really important place for institutions to start, because if you're building up how your electronic health record can collect this information, it really naturally flows into workflows. So in our system, we are collecting preferred name and pronouns or name and pronouns, and it populates the header. And we're working towards collecting that on all of our patients, not just those patients who have a preferred name that's different, just so that that field can always be populated and we know how to address people, and likewise pronouns. Because I think the more that, again, our medical assistants, our nurses are looking towards that, the more familiar it will all become. I think, your point, Frankie, is very important, which is that, even if, so I'm a primary care provider, that's where I care for my patients, and I do hormone management and I do general primary care, and I try to do as much of the specialty care in my office as I can, particularly in regards to things where you would have to go into a gendered space. So I do, pap smears or cervical cancer screening in my office because people are often more comfortable there than going into a gynecologist's office. With our trans feminine patients who have had vaginoplasty, in order for them to get really highly skilled follow-up care, they go to our urology department, and that's typically a male-dominated waiting room. So that can be another stressor. And so learning, as a general provider, how to troubleshoot some issues with neovaginas is really important. But there are some spaces, like our breast center, our breast imaging center is called a women's imaging center. And I understand absolutely historically where this came from, because women's health was also a very underserved area of care. But I think we need to rebrand it a little bit. It's very hard to go into the women's imaging center as a guy and not feel awkward. So we address these in different ways. Our gynecologist tries to schedule people who are male presenting or male identifying as the first visit, so that they just kind of go through the waiting room and into an exam room. So we do a lot more nuanced scheduling with our population when we can. And it's harder, I think it's more challenging when you have a large institution and this is a relatively small population, because we don't have the robust numbers to have, like, this is a half day that's dedicated to this population, nor do people from this population want access only on a half day a week. Another thing that we're looking at doing is setting up a satellite office. It's more of a multidisciplinary office, so that some of those traditionally gendered specialties can actually have some time in this separate office, and that may be a more comfortable place for people to go. So really thinking about, as your patients navigate your system, what would this experience be like? How can we perhaps improve this and really, it requires the structure, but also the staff training that's behind it. I'm wondering if we should pause and see if there's any questions regarding the gendered spaces. Yeah.
I have a question about the EHR, because we struggled with that as well. And I've seen some organizations where they have like an organ inventory, right? Where it's not, if you're a woman, you have this, and you're a man, you have this, but it's just check off if if you have or have had any of these at any point. Is that something that UCLA has or the center has?
We have an anatomic inventory in our system, and it's sort of organs that were present at birth, organs that have been hormonally enhanced or developed, organs that have been surgically enhanced or developed. I use it a lot. I don't know that you have to kind of go into it, right? Find the right tab to click on and go into it. So I don't know how much use it's getting system-wide. So I think, again, in order for these things to be really valuable, it takes a lot of training for people to know where to look for it. We also have a health maintenance module where we track, when people are due for pap smears or breast cancer screening, and that's modifiable. So I can put in cervical cancer screening or breast cancer screening for a patient who's in our record as male. And that's a really useful tool also to be able to kind of switch the health maintenance modifiers.
So at the LGBT Center, it's kind of yes and no. We do have a way of, our providers are well trained to be able to kind of navigate what things are needed for a particular patient. There's also intakes that they do to kind of see where the person is at on their gender journey, what procedures have taken place up until that point, whether or not they've received hormone therapy in the past by any means. And then our community advisory board comes in, and we have a trans-specific community advisory board for our program that helps us really figure out what's going to be the best way for us to ask the questions to get a better result when we're asking these questions in in a clinical setting, and then that provides feedback to our providers. I hope that answers your question.
It does.
Okay.
Yeah. We don't have any of that right now, so I don't have
Some things to start with.
my soapbox.
And so, naturally, some electronic health record systems are much more amenable to this than others. But I think, all of them are mandated to be able to collect the information. It's just a matter of how, and then how usable is that to the end user. That's where the money is. So the other place that often can be, I would say, a barrier to care is this decision about, so for those of you who aren't familiar, there's an organization called WPATH, or the World Professional Association for Transgender Health. And it's a large international organization that periodically updates standards of care for the care of transgender individuals. And it is, the last version was updated in 2011. there's currently a revision in place that was due out last year, and now maybe this year, but probably next year. And the WPATH standards of care is what is often used by insurance companies to determine whether people have met criteria for readiness for a particular gender affirming intervention, whether it's hormones or surgical interventions. And the WPATH recommends strongly that people have a behavioral health evaluation and statement of support in order to be able to access some of these interventions. They softened the strength of that recommendation for hormone management, but it's still a very strong recommendation for surgeries and procedures. And so this is what's come to be known as the behavioral health model, or some people will refer to it as the gatekeeping model. There's been a move within the community to move to more of what's called an informed consent model, where just like we would with any other medical intervention, we see the patient in front of us, do counseling about the intervention that they are considering or seeking, and then it's up to that, informed consent of the person who's receiving those services. And there are some barriers to doing informed consent models, not the least of which is getting insurance coverage for the procedure if you don't have what the WPATH is recommending. But I'm curious to know if folks on the panel, what models you might have used or experienced, and your thoughts about that as people might be building up their consideration of their workflows.
You can go ahead and take it first.
So at our facility, we are a federally qualified health center that operates on informed consent. As someone that answers the emails for folks coming in wanting or seeking gender-affirming care, it is a really helpful model when they're able to access care, especially when they are paying cash and their insurance company is denying them hormone therapy. And they have known after years of therapy that they are ready for that path, and their insurance company is denying them. However, from personal experience, as someone that identified as trans in my early 20s, I'm in my 30s now, but 10 years ago, it was very nuanced. There weren't very many genderqueer people around, and I was still figuring myself out and figuring out whether or not I wanted to transition and have top surgery. My insurance was covering it as long as I had therapy in place, so there was a gatekeeping model for me. And at that point, I was at this place of whether or not I didn't know if I wanted to have children at that point. So what I did was, at that point, made a decision after a long time where I'm waiting until I had children, and now I'm finally having a kid. And now that I'm at this point, I can finally go and seek the gender affirming care that I need. But I could see how the informed consent model, where I was immediately seeking hormone therapy, might have had setbacks for me in terms of being able to have children in the future, things that I needed to decide for myself. So that's, my personal experience has been one where I can see both sides of it, and I can see where patients really need that informed consent model. But for me personally, having my insurance company say you're required to do this first really helped me to figure out whether or not I wanted to have top surgery and what I wanted to do in terms of my parenting and how I wanted to be a parent. So I think it kind of works both ways. So I think it's important that folks, when people see the gatekeeping model, especially for folks that are very certain of their gender, it can really be detrimental to their care. And I think that's where informed consent facilities, I think there's a necessity to kind of have both models in place, because then there's places like the center where they can come first, and if this is the route that they want to take, they're able to get competent care until they're able to get all the other ducks in a row to make sure that they're able to, really get the gender journey that they need that's going to affirm their gender.
So I think the VA, obviously, as everyone knows, is a little bit more of a conservative system, and one that we've had to sort of, we've gone through hurdles, and it's been an uphill climb when it comes to these types of things. There are certain policies in place, and currently at the VA, in order to begin let's say, cross-sex hormone therapy, you need to have a diagnosis of gender dysphoria written in the chart. That's their policy, that's what we have to go by. So when we came together and started our transgender team, we sort of said, like, how can we go about to, offer them, some way to give an informed consent model for those patients that would need it without having to, go through the hurdles that the VA requires. So we've changed, we've sort of, modified our policies and done what we can. So currently what we do at the VA is that if a patient gets referred to us to begin it, if they've already been, on cross-sex hormone therapy or been treated in the past and had the gender dysphoria diagnosis done in the past, even if it's not done at the VA, as long as we can document it, as long as we can, see that they're coming in and meet with them, then we will just do an informed consent, me as the primary care provider, and only if they feel that they would like to be referred to our mental health department or something like that, we will refer them. But if they feel that they are, in a good place and just want to be seen by me at the women's clinic or by endocrine clinic just for management of their hormones, we go about and we just do informed consent for them and continue with their therapy. If a patient is brand new coming to us, what we will do is we have a head psychologist on our transgender team, Angelina Mendanci, and we will send our patients, refer her directly to her, and how she goes about it. And she's actually trained our mental health department at the VA, the Greater Los Angeles. She's had a few different conferences where she's brought in the psychologists, the psychiatrists that work with us, and she basically will meet with the patient and does informed consent. Her only requirement is that they have capacity to make decisions. She will speak to them, making sure, she said, that all the patients have come to her way, and I spoke to her actually yesterday about it, she's only sort of turned down one, and because they didn't have, she didn't feel that they had capacity to make decisions. And she's just there as to ensure that they have capacity, and then to offer them support and resources at the VA and outside the VA, the LGBT Center, anywhere that they need on their journey that she feels that they will need. And once that's in place, she'll refer back to either myself or an endocrine clinic, and we begin therapy. So even though I think the VA, in a sense, has many policies in place and is more rigid and sort of follows or tries, has somewhat a gatekeeping model, I think we've found ways to allow our patients that we feel informed consent is a good option for them to be able to go that route as well. Yes.
I heard Patricia at Kaiser Golden Park, and I oftentimes get the question of what is the youngest age, and that could be 3, 4, 5 is kind of what I'm thinking at to determine gender identity. And I know developmentally, most kids know their gender by 3. So what the mom or dad comes in and says that I've had patients at 3, 4, 5, and the parents are asking, yeah, this, child likes, born male likes to be in dresses. So what do you, on the panel, what do you recommend? What is the youngest age that we can identify?
I'll take that. So I identified as feminine as early as 3 years old. And this is where one has to step out of your role as a provider and really acknowledge that this person, this living human being, knows very well who they are. And perhaps, unbeknownst to them, they were born intersex. I think as providers, as a society, we oftentimes forget that intersex people are born. And intersex is not anything new. It is not anything that is rare. It actually is very, very common, right? Sometimes the genitalia that you see on the outside may be one thing that you don't see on the inside. And so I would continue to ask questions to this child. Most oftentimes, the child is going to know the answers of whom they are and not the parents, because the parents know who they are. And sometimes we unknowingly push our own beliefs onto this other person that has no say and no right over their own body until the age of 18. And we have to acknowledge that this is in fact true in today's society. So I would continue to have conversations with this child, because this child is going to know more about themselves than any other person will know about that child. So to answer the question that was asked for the panel in regards to gatekeeping. As a client and as a provider, I have experienced both. There are pros and there are cons to both. But I think thinking outside the box as providers would be the most important thing. And what I mean by that is I'm dealing right now currently with Kaiser, which is my medical provider. I had started my transition at the age of 21. I was on hormone for X amount of years. I now have breast tissue, right? So what you see is from hormones. And why I say that is because now that I'm trying to get surgeries through Kaiser is not allowing them to happen because I have to have 2 more years with them on hormones in order for them to be able to approve my breast augmentation surgery. And I am not one to be like, let me cover up for you. No, some people need to get their together. Some people need to understand that maybe, perhaps, I don't need to take hormones anymore. Perhaps it is time for my surgery to be approved. I've already gone through this road. Just because you expect me to go through this road with you for your own reasons and for your own beliefs as a provider doesn't give you that right as a gatekeeper. So I see what providers say. I understand what providers say. But again, as an intersex person, I need you to also understand what I am saying. And so perhaps, and this is something that is very new to all of us. Transgender care is very new to all of us. Intersex care is very new to all of us. Just as of recently, the state of California has become the first state to stop intersex surgery. So what does that mean? Is correcting your child's genitalia in order to conform into a certain gender. And if we acknowledge that simple fact, that as of recently, California has the first to be able to stop that, what does that tell us about the care that we are providing our clients? And to go back to that, perhaps, because I'm like, okay, I'm gonna throw you one, but I'm also gonna give you a solution to that. Perhaps going back to our own patients, perhaps asking our own patients, what is it that you need from me in order to give you the best quality of care? Perhaps, I don't know, think of this thing of community advisory board, something that is very, very important to have, and to be asking these very difficult, uncomfortable conversations of what type of care do you think that you need for you to be the healthiest patient I can have? Just a thought.
I think, 1 minute. So I totally agree with that. And I think there is this sort of beautiful place for the hybrid model of informed consent in behavioral health, which is informed consent is really informed consent. It doesn't mean you come to me and I say, great, let's do it. It means you come to me and I say, great, let's talk about the pros and cons, your expectations, your goals. Is this the right whatever for you? And help you make that decision. That's what I do for all of my patients. It should be no different here. And if it seems to me and or to you that you would benefit from talking this through more with a behavioral health provider, let's help you find that person, because that is a huge area of care that's really difficult to access, to find good behavioral health providers who are experienced and knowledgeable in this area of care. So I think you have to have conversations and understand what it is that the person in front of you is needing and wanting and where they're coming from. I just want to get back to the question about pediatrics. So essentially what we know of the pediatric population is that usually by about age 2, kids can identify other people as boy or girl and themselves as boy or girl. And usually by about age 5, they have a sort of a stable sense of gender identity. For people who have gender dysphoria, that process may be a bit delayed. And they may not be able to articulate in any way what they're feeling. They just know that there's something different or often they think there's something wrong about my experience because somebody else has told me that what I just did was bad or wrong. And so having an expectation of kids that they can say, like, you know, I really am a boy by the age of 3. Some kids can, absolutely, but many can't. And what we hear from our older adolescents and adults is that they just remember childhood as this time where they felt like something was off or they felt like they did something wrong, and so they suppress it. Adolescence is another time where things really come up again as kids start to go through puberty and all of this social situation that's going on in middle school that we all remember so fondly. I'm sorry, I have 2 teenagers right now. I'm not in the middle of it all. That's another time where a lot of people will start to get more definition and sometimes start to be able to articulate the experience, especially if they hear other stories. So, you know, I didn't really know what was going on, and then I heard this narrative. You know, I read a story about a trans guy, and that started to make sense to me. So it's really a matter of kind of exposure for a lot of kids. I think what we know is that allowing kids to express themselves in, especially, well, at any age, but in earlier childhood is more important than trying to pin down what their gender identity is. So dress the way you want to dress, do your hair the way you want to do your hair, pursue the activities you want to pursue, hang out with the kids you want to hang out with. And those kids do really well, whether or not they sort of claim new pronouns or claim a new gender identity. So I think trying to get families and society in this place of comfort with uncertainty is a really helpful conversation to have.
Sorry, it's kind of important for me. So at Kaiser, it is the gatekeeper model, and our first step with the process is to refer to mental health. So I guess my question is, for me personally, I mean, I refer all the kids at 5 and above if the parents come in. 3 and 4, I don't, and I kind of say the same thing, let them be who they are. Mm-hmm. So I guess just asking, do you think 5 is I mean, I know what you're saying. At what age would you recommend that I take that step to make the referral?
Yeah, my perspective would be that, first of all, we don't do any medical interventions until at the very earliest a kid starts to go through puberty. Yeah. So, you know, Tanner stage 2 would be the first time we do any medical interventions. So no urgency necessarily to address it from that standpoint before that. The other question is whether to support kids in a social transition and actually perhaps changing name, changing pronouns, and presenting differently. And I would say if a family is considering that, or you have a sense that would be really important for that child, that is probably a really great time to connect them with behavioral health resources if they feel like they need them. But that's not something that we need to kind of give a blessing to. That's a family decision. But it can obviously be a challenging process for the family. So I would say personally, I don't know that I would base it on age as much as what needs are presenting themselves, if that makes sense.
I would like to add that I would understand that the child be referred to mental health, but perhaps the parents are the ones that need it the most, to be completely honest with you. And what I mean by that is perhaps the parents need to be educated. Some of them are not aware that intersex is a thing. Some of them are not aware that transness is a thing. Some of them aren't necessarily, maybe perhaps they weren't even aware that their child had a surgical procedure at birth. So I think it's important for parents to understand why this child is perhaps having these thoughts or why they're going through whatever it is that they're going through. So that they can also, along with that child, be able to navigate whatever it is that they're going to navigate in the future.
And to avoid pathologizing it, but really, making all of these experiences normative and using this as just sort of a source of support for navigating it. But yes, family, absolutely. Yeah.
Kind of like a recap, I think Alexandra hit it on the head with communication. And as a provider, keeping that assertive, open dialogue with the pediatric patient. The WPATH, I'm pretty sure that it offers guidelines and, of course, resources using the Tanner scale. what to do at what stage based on your evaluation of that particular patient. And of course, the final part of that equation is the parental resources to help them deal with what possibly may be happening. Yes. WPATH, I think, is a resource.
Yeah, WPATH's recommendations for pubertal blockade, so medicines that can sort of pause the physical aspects of puberty, is to start those as early as the very first signs of puberty, but there's still an option as long as puberty hasn't completed. And then their recommendations are to start hormone therapy at 16, which, if you can imagine not starting puberty until age 16, that's pretty late. So for adolescents where it seems appropriate, they have included a consideration of starting earlier. And I would say age 13 to 14 is not an uncommon time that we're seeing kids start hormones.
To figure out how to form this concisely, and I'm really glad of that. I'm really grateful for all of the input that you're offering today. My name is Lori Williamson. I'm a registered dietitian, the only one I've seen here today, and I work in private practice in Pasadena with a concentration in supporting trans and non-binary people. And one of the things that you said, or several of you have said that is really ringing with me, is the affirmation piece. And the book, The Body's Not an Apology by Sonia Renee Taylor, talks about how only a person can identify their own sense of what health means to them. And as healthcare providers, I think we often come with, this is optimal health, and we think we can define what someone else's optimal health looks like. And working with trans youth who have a high rate of eating disorders, disordered eating, that we're talking to someone about them defining what their own body identity should feel like, should look like, and then I operate under a body positive model where I'm supposed to be affirming, like, you're beautiful exactly the way you are to everybody that I encounter, and trying to ride that line between those pieces of telling another person that I can identify what their health should look like. And I'm wondering, I mean, obviously that doesn't make for good data for a person to say, this is what my optimal health looks like. We can only provide successful healthcare when we reach what our, data is supposed to reflect. Are there other countries that are doing a better job at this really personalized care, at the deep listening, at the more gray area of what optimal health should look like, that applies so greatly to the trans and non-binary population? As I told you, I think on both sides. Or do you get where I'm going with that? Do you have thoughts about that, about how we can better provide affirming care rather than our identity of optimal care as healthcare providers?
Do you know?
In terms of countries, I mean, I feel like this is where I think it could get kind of sticky in the political aspect. I think that folks that, like, countries that have socialized medicine tend to lean towards having better trans-affirming care. I know that when we were starting our queer women's health program, the Audre Lorde program, we looked to Australia to have really great resources when it came to providing health for sexual minority women, but also trans-affirming care. Every single country does have its setbacks, though. So even though they're providing free healthcare, they still have gatekeeping models. Here, I mean, I think it's easy for me to say, like, with being at the center, the importance of formulating a community advisory board, because that's where we're getting most of we really want to strive to have patient-driven care, and having a community advisory board telling you, and you'll get all kinds of feedback. You'll get folks that have entirely different opinions on, whether or not you should have gendered restrooms, whether we should or not. So these are, you're getting all things across the board in terms of opinions, but it really does help to shape, the act of really having patient-driven care and figuring out, what's going to be the best balance.
I want to say thank you so much for being here. This is very important. And I completely understand the question that you're asking. Perhaps a different country is not the model to look at, but perhaps like what can you as a provider provide to your client is the best way to go about this. And why I say that is because yes, this happens to a lot of the trans and non-binary population. Things that I would have liked as a client for my provider to be able to discuss with myself while they're affirming with my body, while they're talking to me about my transition, but while they're also talking to me about my health and my bodily functions. I would have liked to have had them be completely honest, and I'm going to use this for example, and go ahead and share paperwork of what happens to somebody that is going through their own body issues. For example, what happens if I'm taking laxatives on a regular basis to look good? What happens when I'm not eating correctly? What happens down the road to my body within my bodily functions? I would have loved to have this told onto me and educated, that down the road you're going to see things where you're going to be having bowel movements like this, where you're going to be having to use the restroom like this, where you're going to wake up in the middle of the night and need to use the restroom for X reason in X amount of time. These are things that could happen to your body if you are choosing to do this. So yes, most definitely, your body is everything. Your body is gorgeous, you're fabulous, amazing. But just know that perhaps if you ever want to change, I'm here to listen to you, and I'm here to get you on the path to get your body to be the most healthiest that it can be, so that you don't have to deal with these things later in the future. So that's what I would have liked, is pamphlets or informational things with graphics to let me know what would be happening to my body for my health when it comes to the dietary needs.
I think it's hard to look to other countries as well, because the data that comes out of other countries is all based on those measured health outcomes that we're trying, what are our rates of obesity and diabetes and et cetera, et cetera. And so you're not going to be able to get the model you're looking for from the data I think that we have. And I agree that a lot of other countries who have better coverage for care do have more prescribed models of care as well. I think that from my perspective as a clinician, what I often see is that there are times in sort of the care trajectory that are more amenable to working on certain things. So there are some things we're not going to make any headway on until we manage your depression better. Once you're less depressed, then we can start working on other things. Or top surgery is actually a big area that drives people to start to manage their weight, because their outcomes are so much better if we can get weight down. But then it gets tricky. If you have a history of an eating disorder and we're trying to help you get to that point, how do we do this without being destructive? So it really is very individualized. And I think an information sharing model is a really brilliant approach to it. I'm just here to educate and help you decide what you want to choose.
I just wanted to echo that as well. My name is Linda. I'm the Women's Health and Transgender Care Pharmacist at the VA. I work with Dr. Geft. We see this a lot, and it really is an individual case by case. Like, for example, we may start a patient on estrogen therapy, and we start seeing their lipid panel go through the roof. At that point, I don't look at, oh, well, this is the lipid guidelines. It's telling me to give you this statin medication. Instead, I explain to the patient, I said, this is what the guidelines tell us. We don't know anything about estradiol increasing lipid levels. Let's, what do you think? Is this something you want to start, or let's work on your diet first? Let's see, well, is it really due to the estradiol levels? So reminding yourself to take a look at the patient as an individual, and knowing we have all these guidelines, we have all these recommendations for specific